There are four words starting with O, which has something to do with the eye, E-Y-E-I. One, optic. Two, ocule. Three, ophthalmic. And four, orbit. And we bring in four words starting with O, which has got something to do with the eye. One, optic. Two, ocule. Three, ophthalmic. And four, orbit. And I tell you, two of these four are synonyms to each other. Two out of these four are synonyms to each other. Which two? 1, 2, 1, 3, 1, 4, 2, 3, 2, 4 or 3, 4? One and three, that is his opinion. 1 and 3. Anybody else with a different opinion? 1 and 3. Anything else? Nobody, everybody agrees with 1 and 3. 2 and 4. The second opinion, 2 and 4. Anything else? Going to try only 6 combinations. If you say all 6 combinations, one will be correct. No other opinion? Yes? 2 and 3. That is the third opinion. So we got 1, 3, 2, 4, 2, 3. My opinion is I share with him 2 and 3. Ocule is a Latin word for eyeball. The Greek word is ophthalmic. Optic is a function of the eyeball. Orbit is a moving socket which lodges the eye. That's why we have oculomotor nerve. Those which move the eyeball. And one of the branches of trigeminal is ophthalmic. And we have optic nerve. So many things in the eyeball only. That's why there is a lot of confusion. Then you have got supraorbital nerve, infraorbital nerve. There is the orbit. They don't supply the eyeball. Another word for eyeball is ciliary. When we hear of azociliary nerve, when we hear of ciliary ganglion, they are the ones who supply the eyeball. Okay? Now, why the three branches of trigeminal were called as ophthalmic, maxillary, mandibular is only because oculo was already taken by the motor. So the third cranial nerve. So the fifth cranial nerve branch had to use the Greek alternative. Because actually trigeminal is a Latin word. Because most of the anatomical terms are Latin. But somewhere we use Greek because of the other one being already used. You can't have two nouns in the same thing. Oculomotor nerve and ophthalmic. We are dealing with ophthalmic nerve in the first half of the class. The second half of the class will deal with cortical control of movements of eyeball. Ophthalmic nerve is first division of trigeminal, the other two being maxillary and mandibular. Trigeminal is considered the largest cranial nerve because we are not counting first and second cranial nerve has true cranial nerves. Otherwise, if you look at the axons, second cranial nerve is most number of axons. But trigeminal has got fewer. But still, ophthalmic of the trigeminal has got 25,000 axons alone. Ophthalmic. And they are all sensitive. Maxillary has got 50,000 axons. Based on this arithmetic progression, mandibular should have 75,000. And it has. But 10% of the 75,000 are motor. Because mandibular is a mixed field. Mandibular is a mixed field. Ophthalmic in humans are pure sensory because the upper jaw does not move. It's only the lower jaw which moves downward. So only mandibular is a mixed one. Now let me ask you a little bit of comparative anatomy. In crocodiles, 4 options, only upper jaw moves up. Second, only lower jaw moves down. Third, both the jaws move. Fourth, neither of the jaws move. And repeat the options again. In crocodile, only the upper jaw moves up, only the lower jaw moves down, both the jaws move, or neither jaws move. Anybody who says neither jaw moves, I throw into a bit of crocodile. It's not going to move the jaw, right? We know the jaws move. Electromyographic study of the maxillary and mandibular division of crocodile shows that only lower jaw moves down. Because the maxillary nerve of crocodiles are also pure sensory. The illusion that we get that the upper jaw moves up is because at the rate at which the lower jaw moves down, at that same rate it extends its neck. By extending the neck and the lower jaw moving down at the same rate, it gives us an illusion that the lower jaw is fixed and upper jaw is moving down. Are you getting the point? In fact, all vertebrates which have jaws, only the lower jaw moves. Okay? There are certain vertebrates which do not have jaws. Can you give me one large example of a vertebrate where the jaws don't move? When the lower jaw is not present, is a shark. But all cartilages of fishes, they don't have a lower jaw. And we have got a movie called Jaws, and the movie about sharks. I have told you that there is no lower jaw. How can you have jaws? Anyway, coming back to the ophthalmic nerve, which is also a pure sensory nerve. Before the ophthalmic nerve enters the orbit, it divides into 3 branches. Mesociliary, frontal and lateral. Mesociliary, frontal and lateral. But from medial to lateral. We'll deal with lacrimal first. Lacrimal nerve goes through the lacrimal gland, which is present in the upper lateral part of the orbit. So the gland goes to the orbit fissure and goes to the upper lateral part. Before it reaches the lacrimal gland, it receives a communication from zygomatico-temporal nerve. And zygomatico-temporal communication is the one which carries the postganglionic parasympathetic fibers to supply lacrimal gland for lacrimal secretion. Okay? The communication between zygomatico-temporal lacrimal are post-ganglionic parasympathetic fibers. So lacrimal itself is sensory nerve. The communication is in the secretomotor valve. This post-ganglionic parasympathetic fibers, obviously because they are post-ganglionic, they must have relayed somewhere. Where did the relay of the lacrimal gland occur? I'll give you four options. These are parasympathetic fibers, so they have two parasympathetic ganglia. One, ciliary ganglia. Two, pterygopalatine ganglion. Three, otic ganglion. Four, submandibular ganglion. Okay? Because these are the only four parasympathetic ganglia of the head neck. Ciliary ganglion, pterygopalatine ganglion, otic ganglion, and submandibular ganglion. These are for pterygopalatine ganglion. Don't confuse it with ciliary ganglion. Although ciliary ganglion lies in the orbit, lacrimal nerve also lies in the orbit. Ciliary, as the name suggests, will supply only eyeball, not lacrimal gland. Lacrimal gland, like upper palatine glands and lower palatine glands, are all supplied by ganglion which carries fibers from facial nerve. Superior cerebellum. So ophthalmic nerve's lacrimal branch will be pure sensory to the lacrimal. Frontal nerve, the middle branch of the trigeminal, passes from the upper part of the orbit and doesn't supply anything in the orbit. It divides in the orbit into supratrochlear and supraorbital nerves. And they supply the forehead and the scalp up to the vertex, the highest part of the eye. Okay? So frontal is meant to supply only two branches, supply the forehead and the head, the scalp, by a supratrochlear and supraorbital branch. If you already drawn your journal, you will remember the various nerves and the blood vessels which accompany each other into the scalp. Nasal ciliary is more interesting. The name suggests it has to supply the eyeball and it has to supply the nose. It supplies the entire cornea, nasal ciliary supplies the entire cornea and ophthalmic, the whole ophthalmic will supply the upper half of conjunctiva. The lower half of conjunctiva will be supplied by maxillary nerve. Don't confuse cornea with conjunctiva. Cornea is a transparent circular thing which appears as dark brown, blue, green, whatever color. So it's not the color of the cornea, it's the color of the iris which you can see in the transparent cornea. The whole cornea is supplied by nasal ciliary alone. The upper half of conjunctiva, which is covering the sclera, are supplied by all the three divisions of ophthalmic. Lateral part will be by lacrimal, middle part will be by frontal, and the medial part will be by nasal ciliary. The then you have the oculomotor supply in the eyeball. They supply the whole cornea and medial part of the upper conjunctiva. Then it gives out two branches. One branch is called as posterior ethmoidal nerve. The other branch is called as infratrochlear nerve. Posterior ethmoidal nerve and infratrochlear nerve. The intratrochlear nerve supplies the skin of the root of the nose, the root, the beginning of the upper part, skin of the upper part of the nose. That's intratrochlear. And posterior model will enter the cranial cavity again to supply the dura mater of the anterior cranial portion. After these two branches are given off, the nasociliary leaves the orbit and enters the cranial cavity with a new name, anterior ethmoidal nerve. Actually, there are some people who consider posterior and anterior ethmoidal nerve as branches of nasociliary and intratrochlear as a continuation. Because it appears that way. Intratrochlear is in line with the nasociliary. But the intratrochlear is a slender branch. Posterior ethmoidal is also quite slender. The bulkiest branch is the anterior ethmoidal. That's why anterior ethmoidal is considered as a continuation of nasociliary. Anterior ethmoidal nerve also enters the cranial cavity like posterior and it supplies the dura mater of the anterior cranial fossa like posterior. So both the ethmoidal nerves supply the dura mater of the anterior cranial fossa. Anterior ethmoidal does not stop there. It enters the nasal cavity. That's why the name nasociliary. Right? It enters the nasal cavity divided into two branches. One supplies the nasal septum, antero-superior part, antero-superior half of nasal septum. The other supplies the lateral wall of the nose, antero-superior quadrant of the lateral wall of the nose. I repeat again, the anterior quadrant is entering the nasal cavity. How does it enter the nasal cavity from anterior cranial fossa? Similar to how olfactory nerves travel to the cranial cavity from the nasal cavity. The cranial plate of the wall. From the sides of the cranial plate of the wall, there is a special opening for anterior ethmoidal to enter the nasal cavity. As soon as it enters the nasal cavity, it divides into two branches. One branch to supply the antero-superior half of nasal septum and another branch to supply the antero-superior quarter of the nasal wall. Then the nerve comes out and supplies the external surface of the nose, lower half. External surface of the nose, lower half. Here it gets a new name, external nasal nerve. External nasal nerve. We say there is a rule which says nerves don't change names when they change regions. Arteries do. Like the artery which was in the axilla is called axillary artery. Before that it was below the clavicle, it was called subclavian artery. Then it enters the arm, it's called brachial artery. Keep on changing their names when they change the region. Whereas right from axilla, we have got ulnar nerve. And that name ulnar nerve remains even when it reaches the hand. Right from axilla we have the radial nerve, which by the time it reaches the radius it divides. And when radial nerve is there with the radius, it's always in the humerus. Upline is the division. So, median nerve starting from axilla, going all the way to the hand, and median nerve. So, nerves don't change names when they change regions. Nasociliary is the only one which has changed its name. Not once, but twice. It was nasociliary in the orbit, and is anterior in the cranial cavity. It is external nasal. Same nerve changes its name. With that, we come to the end of the discussion. The reflex associated with ophthalmic nerve is conjunctival reflex and corneal. Touch the cornea with a wisp of cotton, both the eyes will blink. Touch the conjunctiva, upper half of conjunctiva with a wisp of water, both the eyes will blink. The efferent part is by facial nerve which blinks the eye. The afferent part, upper conjunctiva is ophthalmic, lower conjunctiva is maxillary. So the whole cornea is ophthalmic. Therefore, it's always better to do a corneal reflex for ophthalmic nerve because conjunctiva is an overlap by two nerves. So not very sure if that overlap is exactly occurs midway or little up and down. Okay? Next topic that we are discussing is cortical control of movements of eyeball. We already had a class on 3rd, 4th, 6th grade and you saw that they are controlling the muscles which move the eyeball. Recti move as per their names. Superior rectus helps in moving up, inferior rectus helps in moving down, median to the median side, lateral to the lateral. Obliques do their action and reverse to their names because there is certain post-equatorial. Superior oblique lifts the eyeball up, but post-equatorial motion. So the pre-equatorial motion goes down. And nomenclature of movements of eyeball are based on what happens to the cornea, not what happens post-equatorial. So when the superior oblique raises up the post-equatorial one, cornea goes down. Depression. Inferior oblique reverse. Upward. This was an oversimplification. Let's not try to complicate it. Luckily, medial rectus and lateral rectus have no cause for confusion. Medial rectus helps in moving the eyeball medially, lateral rectus helps in moving the eyeball laterally. And the eye is better designed to move horizontally. That's why we write horizontally. Either left to right to left, doesn't matter. But it has to be written horizontally. It's not that we can't write vertically. If you write vertically, you find it difficult to read because the human eye is not designed to scan vertically from up to down. It's not that we have been trained. We have got specified muscle for horizontal movements. Vertical movements are more complex. Because two muscles help in looking up. Superior rectus, inferior oblique. And what are the different roles? When you turn the eyeball laterally, let's assume my right eye. When you turn the eyeball laterally, the superior rectus on the right side is best designed for elevation. Superior rectus, the right eye is best designed for elevation because line of pull of superior rectus is at right angles to the axis around which the movement is. So, when the eye is turned laterally by lateral rectus, Superior oblique helps in looking up. Superior rectus helps in looking up. Inferior rectus helps in looking down. When you turn the eyeball medially, just look at my right eye. When you turn the eyeball medially, the superior rectus and inferior rectus are parallel to the transverse axis around which the upward downward movement is. If they are parallel to the axis around which the movement is, they can't bring about that movement. Angle 0, sin 0, no movements. So if the eye is turned medially, superior rectus and inferior rectus can't elevate, can't depress. Instead, So when the eye is turned medially, superior rectus will intort the eye, rotate the eye towards the nasal canvas, and inferior rectus will extort the eye. When 12 o'clock position of the eye turns medially, it's called intorsion. The 12 o'clock position moves outwards. That is 6 o'clock position of the eye moves inwards. That's called extorsion. So in the medially adducted eye, superior inferior recti can only torsion the eye. In an abducted eye, they elevate and decrease. Now let's look at the obliques. When the eye is turned medially, the obliques are well aligned to be at right angles to the axis of upward downward. So obliques help in elevating, depressing when the eye is adducted. When the eye is abducted, their line of pull and the axis of movement is the same. They can't elevate nor depress. So at that time they will torsion. So adducted eye, obliques elevate, depress. Abducted eye, recti elevate, depress. Okay? So although we read in anatomy books, superior oblique muscle downwards, laterally and intorsion, three movements. The lateral movement of the superior oblique is superfluous because there is a vessel designed for lateral movement, lateral rectus. So why should it have a secondary action of turning eye laterally? It doesn't turn the eyeball laterally except in a cadaver or when it alone acts and nothing else acts. So eyeball is the orchestra. Human eyeball is like an orchestra. You can't have only one instrument doing the job. All of them acting together. So medial rectus lateral movement is a medial lateral rectus. It doesn't require the summation of two obliques to bring about the lateral movement. And for long, the superior oblique has been called as the cheater's muscle because it helps in looking down and lateral. Cheater. But now we know that if the eyeball is turned laterally, the downward movement by inferior rectus, not by superior oblique at all. So when you are looking at downwards towards the right, it's the inferior rectus with lateral rectus which helps in seeing. But what happens to the left eye? The left eye is turned medially and downward, which is by superior oblique. But the left eye cannot help in looking to the right side because the nose comes in the way. Okay? So, superior oblique was never a cheater. It was only we anatomists who would cheat each other and cheat the students as well. So, students say, anatomy said superior oblique downward lateral, and physiology said downward medial. and the physiologists don't do anything. So they keep the downward lateral movement anatomy of tortoise. Because paralysis of superior oblique does cause the eyeball to go upward medial. If paralyzed superior oblique, eyeball goes upward medial, so its action intact should be downward lateral. But now you know that axis and all those things come into play. It's not downward lateral at all. It is downwards when the eyeball is turned medially. So you have forgotten what physiologists taught because they taught wrong thing, and you remember what anatomy taught. Then you go to ophthalmology. So what is the action of superior oblique? You all say downward lateral. Say, what have you learned in anatomy? That is your wrong thing. It is downward medial. There lies no reference. In a medially rotated eyeball, when you erected eyeball, it has been downward. Is this clear? So take the anatomy's lateral movement, medial movement with a pinch of salt. Okay? Because physiology taught teaches us what happens in life. Anatomy teaches what happens after death or paralysis. Okay, so then the person is paralyzed, he is paralyzed alone because it has got a separate nerve supply. It's the thinnest cranial nerve of all. Easy to get damaged anywhere. Let's come back to cortical control. And we will focus primarily on medial lateral control. Because that's what the eye is designed for. Now, for medial lateral control, the action medial rectus and lateral rectus. Medial rectus is supplied by third cranial nerve lying in the upper midbrain, and lateral rectus supplied by abducens which lie in the lower pons. So when you turn the eyeball to the left, one eye laterally rotates, the other eye medially rotates. The third and sixth cranial nerve have to act together. Because when one eye turns laterally, the other eye turns medially. When the first eye turns medially, the other eye turns laterally. The third and sixth are orchestrated by the same pathway. Frontal eye field of the forebrain, frontal eye field for the frontal lobe, causes the eye to move laterally to the opposite side. Means left frontal eye field causes the eye to turn to the right. Right frontal eye field causes the eye to turn to the left. Let's now focus on left frontal lobe, and we are focusing on the action of moving the eyeball laterally. Moving the eyeball to the right. From left frontal lobe, the fibers go to the right PPRF. Right PPRF. Pontine, paramedian, reticular formation. Pontine, paramedian, reticular formation. From the left frontal lobe, it goes to the right PPRF. Where is this located? In the reticular formation? It's located throughout the brain stem. This paramedian pontine reticular formation for control of eyeball is located in lower pons, just next to the midline. From paramedian pontine reticular formation on the right side, axons, one axon goes to the sixth cranial nerve nucleus, another axon goes to the third cranial nerve nucleus of the opposite side. One branch from the PPRF goes to the sixth cranial nerve, which is lying very close to it. And the other goes all the way up to the upper mid-brain and supplies the third cranial nerve for the medial rectus combination. This pathway is called as interneuron pathway or internuclear pathway. When we are talking about nucleus, we are talking about abducent nucleus, and we are talking about the oculomotor nucleus, which is meant to supply the medial rectus. So cortex to PPRS is called upper motor neuron or supranuclear pathway. PPRF to the nucleus is called internuclear pathway, and from 6th cranial nerve nucleus to the muscle and 3rd cranial nerve nucleus to the muscle is called as intranuclear pathway or lower motor neuron. Remember, when you talk about movements of elbow, hip and all those cortical controls, we say cerebral cortex to spinal cord, spinal cord to the muscle. We talk about U11, we talk about L11. Upper motor neuron, lower motor neuron. We don't talk about interneuron. There is an interneuron, but it is so small that clinically is not important. Functionally is important, but clinically is not important because if the small interneuron gets damaged, the lower motor neuron will also get damaged. A small lesion affecting interneuron will also affect the element, and the effect will be on lower motor neuron problem. So clinically, you can get a lesion of upper motor neuron alone, you can get a lesion of lower motor neuron alone, or interneuron plus lower motor neuron, which is also lower motor neuron. You don't get isolated interneuron damage. Here it can occur. You can get a supranuclear lesion, you can get an internuclear lesion, and you can get an intranuclear. Because of the long interneuron. So let us say we want to look at the eyeball lateral towards the right side. Left frontal eye field will send a pathway to right PPRF. And right PPRF will supply the right sixth nerve, which will cause the right eye to turn laterally. And right PPRF sends the information to the left third cranial nerve, which will cause the left eye to turn medially. Is it clear? That's the control of horizontal movement in that. Now let us see what will happen if some of these pathways gets damaged. Let us assume that the left frontal eye field is damaged, or the axon, which is going towards PPRF, is damaged in the internal capsule or wherever. The left at rest, both the eyes look conjugate in front. Conjugate means the two visual axes are parallel. When you ask the person to turn to the right, he can't. He can't turn the eyeball to the right. When you ask the person to turn the eyeball to the left, both eyes move to the left. Because right frontal eye field is normal. Eyes can turn normally to the left. So at rest, conjugate, movement to right not possible, movement to left possible and conjugate. So it remains conjugate wherever the movement happens. Now you might think he is unable to look to the right, he can't turn the eyeball to the right, but that's not true. He can't turn the eyeball voluntarily to the right. Now if there is a mosquito which is flying in the air and you are focusing on the mosquito and it moves from left to right, you are following the mosquito and the mosquito goes to the right side. The eyeball will go to the right and go to the right. He could not bring about voluntary movement. So when he is following an object, he is able to bring about that movement. That's surprising. The voluntary movement to left and right side is by frontal lobe. The pursued movement is by occipital lobe. And the pathway of frontal lobe was that way, occipital lobe is not that way. So you can pursue it. So the first type of movement we should talk about frontal lobe movement is called as saccadic movement. S-A-C-C-A-D-I-C. Saccadic. Saccade means jumping or jerky. When you are reading a book and the book is not moving hopefully, we have to move our eyes to read it. And then we jump from letter to letter, sometimes words to words, and sometimes keywords to keywords. Okay? All the other things. It depends on how fluent are you in the language. If you are fluent in that language which you are reading, you will jump from keywords to keywords. The other things are in the peripheral field. Macular eye will see only the keywords. When you are less fluent with the language, you will go from word to word. You read every word. You are jumping from word to word. And if you are still less fluent with the language, you will go from alphabet to alphabet. Okay? That's how you read. If the teacher, examiner is correcting your paper, they only look for keywords. They don't check your grammar. Keyword is there, yes, yes. See? Paper completed. 1 page, 5 seconds. So that's all that is done. If you have got too many keywords in that same page, the teacher is irritated. Why is it crowded? There are 44 pages given. Why didn't he write loosely? Keywords should be 5 or 6 in one page and with big diagram. And you just have an overall look at the diagram, you know that the student knows. Nobody is going to draw boldly something which he doesn't. Okay? That's why that rule. Number of pages multiplied by number of diagrams divided by size of handwriting. That's the marks you get. Number of pages multiplied by number of diagrams divided by size of handwriting. No diagram, 0 marks. Because multiply, right? Coming back to it. So what you have to draw is important. What is given in your journals to draw? Only those diagrams should be drawn. There are some people who try to draw Down syndrome, slanting eyes and all those things. They are not there in your journal to draw. You are not supposed to draw that. What we have given you in the journal to draw, those diagrams and similar diagrams can be drawn. So these are the saccadic. What will happen if the interneuron is damaged? If the interneuron is damaged, at rest the eye looks straight ahead. And let us say that the interneuron damage is of the right PPRF and the pathway of right PPRF going to the left third nerve, passing through the medial longitudinal fasciculus. Now, medial longitudinal fasciculus are so close to each other in the midline that damage to one medial longitudinal fasciculus is the other medial longitudinal fasciculus is also damaged. So the lesion here is PPRF and medial longitudinal fasciculus of both sides. Right PPRF and medial longitudinal fasciculus of both sides. When you ask the person to look to the right, neither the right sixth nerve will act nor the left third nerve will act. When you ask the person to look to the right, he can't turn the eyes to the right. Then it is considered the other way around. Ask the person to look to the left. Left is controlled by right frontal lobe and left PPRM, which is intact. Left PPRM to left sixth nerve is also intact. But left PPRM to right third nerve passing through the medial longitudinal, that is damaged. So at rest, the eyes look straight ahead. When you ask the person to look to the right, he can't look to the right. You ask the person to look to the left, only the left eye moves. This is called as one and a half syndrome. 1.5 syndrome. Why is called that? When you ask the person to look to the right, he can't look to the right. One is gone. One movement is gone, turning the eye to the right. And when you ask the person to look to the left, only one eye turns to the left, the other eye does not. That means only half movement is possible on the left side. So 1.5 movements are lost. So conjugate at rest and disconjugate on movement. This is internuclear of the movement. The fact that the muscle is not paralyzed can be tested by mosquito flying back. Mosquito is flying from the right to the left, the eyes will look to the mosquito and follow it to the left. Both the eyes will turn to the left and again it can turn to the right, following an object. Because following an object is controlled by occipital lobe, not acting through PPRM. Is this quite clear? So this is called as saccadic movement. The second type of movement is called as smooth pursuit. Smooth pursuit. You already said smooth pursuit is by occipital lobe and the object that you are focusing on, when it moves, you will follow it smoothly. You will not jump. You will not wait for the object to move and jump there. You are not voluntarily doing it, it involuntarily follows an object that you are focusing on. That object. Except what you can do is, when you are in a slow train and you sit next to the person who is sitting on the window and observe that person's eye when he is looking out of the window. When looking out of the window, train is moving ahead, objects by the side appear to move behind. When it is moving behind, his eyes will catch hold of one object, eyes will turn behind. Then when the object goes out of the field, he jumps, the eye jumps forward, picks up another object which is moving behind, and he will have an oscillatory movement in the eye. What? Which is called dystagmus. When you are looking at an object, you are forced to catch hold of the object till it goes out of the field. So that movement of focusing on the object which is moving is controlled by occipital lobe. And coming back and jumping back to the front again is done by frontal lobe. Nystagmus therefore has got a slow component and a fast component. The slow component is by occipital lobe. The fast component is by frontal lobe. Okay? The slow component is involuntary. The fast component is voluntary. Okay? Therefore, if the train moves too fast, then you don't appreciate the distance. Because you can't catch hold of anything. Things are moving so fast. But when the train is moving slowly, at times you can see the distance to be quite pronounced. Because the activity of the drift should be slow and returning back should be fast. They don't do it so. It's not like a pendulum. This time is not like a pendulum. It's equal to and fro times. So that is called as pursuit movement controlled by oxygen. A third type type of movement is called as fixity. Fixity movement. Suppose you are focusing on an object in front of you. Somebody turns your head to the left side. You continue to look to that object by the eyes fixing on it. Somebody turns the eyes to the right. You still continue to look at the object. The object is fixed, head is moving. Fixity. Object is moving, head is fixed. Smooth person. Fixity movements is by occipital lobe via vestibular apparatus. Occipital lobe via vestibular apparatus. So the head moves, the vestibular apparatus detects the semicircular canal, detects how much the head has moved. Exactly similar, the eye should move in the opposite direction. So we keep fixing on that object. Is this clear? So first was saccadic, frontal lobe, jerky, jumping movement. Second was smooth pursuit, occipital lobe. Third is fixity, where the occipital lobe is controlling, but via vestibular apparatus. The fourth type of movement is called as vergence. V-E-R-G-A-C-E. Vergence. Normally, one medial rectus acts with opposite lateral rectus. Here, one medial rectus is acting with other opposite medial rectus itself. That means your two eyes are converging. One medial rectus acting, other medial rectus also is there. It's called as convergence. Convergence is controlled by occipital lobe. And going back to the original position is called as divergence, which is also by occipital lobe. So convergence and divergence are vergence movement controlled by occipital. Remember, from anatomical position or rest position, you can't diverge first. You can't have one eye open left and another eye open right. You can converge, then restore. Then restoration movement is called divergence. So you can converge only, then you can have it. So if you are trying to look at a far object, your eyeballs are parallel to each other, visual axes are parallel. Suddenly you are asked to look at a close object. The two eyes will converge and look at the close. The convergence controlled by occipital lobe is both medial rectus contract. When both medial rectus contract, proprioceptive fibers from the medial rectus goes to a unknown nucleus of Purlia. Nucleus of Purlia. P-E-R-L-I. Where it is located is not very clear, but it is there somewhere. The nucleus of Purlia, it sends information to both the Edinger-Westphal nucleus, the accessory of the lobe. And by going to the Edinger-Westphal nucleus, the pupils will constrict and the eyeballs, the lens will accommodate. When both the medial rectus contract, we are trying to look at a closer object. There will be a simultaneous pupillary constriction and accommodation. So all three take place together. Okay? But the convergence in occipital lobe and controlled by your will. The constriction and the accommodation is involuntary. When something happens involuntarily, it is called a reflex. When something happens voluntarily, it is called as a reaction. There is always this confusion. Is accommodation a reaction or accommodation a reflex? Accommodation has got three components. We said convergence in the eye, constriction of the pupil, and ciliary muscle contracting for causing accommodation. So three C's. ciliary contraction, constrictor pupillary, and medial rectus convergence. The medial rectus convergence is a reaction. The other two are so accommodation. When you are asked, accommodation is a reflex. Constriction during accommodation is a reflex. Convergence during accommodation is a reaction. Is it clear? The fifth type of movement is called as doll's eye movement. Doll's eye. D-O-L-L apostrophe S. Doll's eye movement. You must have seen certain dolls. They blink their eye. You tilt the doll, the eyes also move. So, something similar happens. Person is lying supine on the bed and he is unconscious. When he is unconscious, he can't see anything. He is lying supine, he opens his eyes is looking straight upward towards the ceiling. Looking straight up towards the ceiling, I will take his face and sharply turn his head to the right. You sharply turn the head to the right, the eyes will turn to the left. Continue to look at the ceiling. You turn the eye forcibly to the left, the eyes will continue to look up. This control of sharp turning is important. Simple turning not only. Sharp turning is sending a reflex to the vestibular apparatus. And the vestibular apparatus corrects the eye to continue to look at the same. He is not seeing anything. He is not fixing things. He is not fixing the movement. But the pathway is similar. It does not start from the occipital lobe. It starts from vestibular apparatus itself. And the eyes will act as if it is fixing and looking at an object on the ceiling when there is nothing there. This reflex is called as doll's eye. If doll's eye movement does not occur, that means if you turn the head sharply to the left, eyes also move sharply to the left, not restoring back. Then you will say doll's eye movement negative. Then you do all the brainstem reflexes that you have learned. If all brainstem reflexes are negative, the person is declared as brain dead. And this brain dead has to be certified by another independent doctor. He will perform it himself. You have performed it yourself. There is not some independent other disinterested person to do it. Because once you have declared the person brain dead, his relatives and you can decide whether his organs should be transplanted to other needy people. Now that needy people have rich people. They have paid you handsomely to declare the person brain dead. They have paid the relatives of the brain dead person also to donate to them. Therefore, we require another doctor to certify that the person is brain dead. And the other doctor also handles the we can't help it. But this is what happens. Brain dead has to be declared. All brainstem reflexes should be negative. This is one of those causal. The causal movement is present in brainstem not dead. And when you say the person brain dead, we are referring to brainstem dead, not cerebrum, not cerebellum, not thalamus, only brainstem. Okay? Just to touch up, looking up and looking down, although less often down. Looking up is done by superior rectus and inferior oblique. Both of which are supplied by third. Looking down is done by inferior rectus and superior oblique, both of which are done by third and fourth cranial, which lie in the midbrain. So when you're looking up and down, pause does not come into play. It's only the midbrain. In the interior part of the midbrain, there is a nucleus called as interstitial nucleus of Kayal. Inside the brain, there is interstitial nucleus of Kayal. Kayal is spelled as C-A-J-A-L. J in German is pronounced as Y. So Kayal. Okay? That's why in cerebellum, you heard of Purkinje fibers? Purkinje was a person who came to Germany for higher studies. You asked, what's his name? He replied, Santiago Ramon y Purkinje. Germans, Purkinje, P-U-R-K-I-N-J-E. Because J is from why? Okay? No, it's not J. Santiago Ramon y Kayal. This was Johannes Evangelista Ritter von Purkinje. Purkinje was his name. They spelled it as J. And he was von. They wrote it as V-O-N. Because V in German is stronger than like Volkswagen. It's not Volkswagen. Volkswagen. It is Folk means ischemic contraction, not Volkswagen. Folk. His name was Purkinje. They spelled it as J. We call it as Purkinje. Anyway, coming back to so interstitial nucleus of Kayal. This nucleus is meant for looking downwards. This is meant for looking down. Dorsal to the midbrain, dorsal to the midbrain is a pineal gland, and the midbrain is connected to pineal gland via the inferior pineal stalk. In that inferior pineal stalk lies the nucleus. That's called as nucleus of posterior commissure. This nucleus of posterior commissure is meant for looking upwards. So interstitial nucleus is meant for looking downwards. Posterior nucleus of posterior commissure helps for looking upwards. In Perinaud syndrome, the nucleus of posterior commissure is damaged. Interstitial nucleus has got a different blood supply. Therefore, eyes can't look upward in Perinaud syndrome. Eyes forcibly look down. Okay? In hydrocephalus in a child, there is pressure on the CSF outside in the subarachnoid space. That presses upon pineal gland, that presses upon the nucleus of posterior commissure, and the eyes look down. This is why we call it as sunset sign. That's nucleus of posterior. With that, we come to the end of the discussion.